Good afternoon, everyone. Uh, I'll begin with the case presentation. My patient was a 42-year postmenopausal female, which presented to another center with the complaint of abdominal pain, multiple episode, and vomiting multiple episodes. There she was evaluated under the surgical team, and she was diagnosed with acute necrotizing pancreatitis in 2021. On workup, she was found to have a raised IPTH level of 121, and after management of the acute pancreatitis, she was referred to the surgical team. Her calcium was 9.7 with a raised ALP of 516. Uh, for further workup, MRI was done, which was suggestive of a mass lesion in the left thyroid lobe. It was 2.2 into 1.7 into 2.7, and a suspicion of intrathyroidal parathyroid was made. Then she was taken up for surgery in January 2022, which was left inferior parathyroidectomy. IOPTH monitoring was not done, and one second. The pre-op IPTH was 2,500 picogram per ml, and there was a mild decline in the PTH level to 737 picogram per ml, but it was not to the normal level. And post intra-op details are not much known, and post-operative course was rather uneventful. However, she does not have a calcium report which we could trace. Now she has now in 2023 she came to us with the complaint of neck swelling with proximal muscle weakness and mild upper abdominal pain on and off. uh, for I forgot to tell that during the last surgery, the histopathology report had told that it is a parathyroid adenoma. It was confirmed. When she presented to us, she had a 2 into 2 centimeter well-defined, firm, non-tender swelling in the left supraclavicular region around 2 centimeter above the clavicle, and there was a 3 centimeter scar above the swelling, as is noted in the picture. And rest of the examination was near normal. On further workup, her PTH levels were raised 472 picomole per liter. Calcium was raised 13, and ALP was also high, 1482. Uh, on ultrasound, she had a 10 into 20 into 23 of uh, round nodule. One second. And it was a large, heterogeneous, enhancing hypoechoic shaped mass just inferior to the lower pole of the left thyroid, and it had ill-defined fat planes with the lower pole of the thyroid and the adjacent musculature. And there were subcentimetric cervical lymph node with loss of fatty hilum. Features were suggestive of left parathyroid adenoma. To further categorize the lesion, we went ahead with the Technetium 99 MIBI scan, and I would like to invite Dr. Aftab, additional professor from nuclear medicine, to discuss the MIBI scan in detail.
So this is maybe scan of the patient. 20 millicurie of technetium maybe was injected to the patient. As you can see in the first left side image, left lobe of thyroid is slightly longer than the right lobe, and the second image is delayed image, that is 45-minute image. So the normal thyroid tissue are showing the washout of the radio tracer. With retention of radio tracer, we can see at the inferior pole of the left lobe of the thyroid. So probably this is the our parathyroid adenoma. This is the perfusion image. In this scan, patient is injected red tracer under the camera. So as the tracer injected and the acquisition is started, so sometimes we see the plus of activity at the adenoma side. In this case, this perfusion image is actually not seeing such a plus. So it does not add anything, but yes. Early and delayed static images are showing increased uptake at the lower pole, and that is parathyroidinoma. Here, this is the now third slide. Yes, this is the spexity of the same patient. At you can see a small nodular lesion at the lower pole of left lobe of thyroid. That is the parathyroidinoma. Left inferior parathyroidinoma. And this image is thyroid subtraction image, where the patient is also thyroid scan is done. Then parathyroid image is subtracted by the thyroid image. So last image at the lower side, you see tracer activity only after subtraction of the thyroid activity. So at the lower pole of left lobe of thyroid, you see the activity. So this is the parathyroid.
So thank you, sir. Then to further, since it was a recurrent or a persistent disease, we went ahead with the 4D-CT to further characterize the disease. I would like to invite Dr. Asmita, Assistant Professor, Department of Radio Diagnosis, to uh, tell about the disease. Thank you.
Yes, we did the 4D-CT for the parathyroid. Basically, 4D-CT is a multi-phagic imaging where last is a time is taken as a fourth. So in this case, NCCT is firstly we do the non-contrast study of neck that covering the thyroid gland, including the parathyroid. So scan is taken from the mandible to the upper mediastinum just to look for the entire parathyroid gland or possibility of ectopic location of these glands. So first we take the non-contrast, then we take the arterial phase, which is normally taken as 25 to 30 seconds after giving the contrast agent. Then last phase, the venous phase, which is taken approximately around 60 seconds of the contrast injection. So provided images of this patient, here we can see, Akriti, can you show me the pointer in upper image, like fourth one, yeah. Here we can see a relatively well-defined. Why I am saying well-defined? In anterior aspect, we can see margins of the lesion is looking well-defined, but posteriorly it is not as clear. So this is a mixed type of lesion where we can see a well-defined part in anterior aspect, but posteriorly the margins are not as clear. And in the second image upper, the margins of the lesion with the left lobe of thyroid is not clear. So we can see a relatively ill-defined hypotense lesion in lower pole of left lobe of thyroid, and this lesion is extending posteriorly in the tracheoesophageal groove. And apart from that, on NCCT we should always look for the calcification, hemorrhage or any fat content with it. So we are not seeing any calcification, hemorrhage or fat. So typically here we can see on NCCT we are seeing relatively well defined or large lesion. The lesion size is approximately more than 3 centimeter. We can see a 3 into 3.5 centimeter on NCCT. Moving to the next slide. So just go back one slide prior. So this is a arterial. Basically, it is an arterial phase image. Akriti, next one. Yes. So this is a basically arterial phase images. Here we can see. Moving to the next one, please. Next slide. Yes, we can see the lesion is heterogeneously arterial enhancing and showing a intralesional prominent vessel within that. We can see clearly in the fourth image, upper fourth images, lesion is relatively heterogeneous arterial enhancing, but it is not as more enhancing like thyroid. So we can see a heterogeneously arterial enhancing lesion in the lower pole of left lobe of thyroid. When talking about the vascular plane or adjacent structures plane, just next slide. So we can see a fat plane in the left common carotid and IGP is lost, but we are not see any invasion within that. Entirely the fat plane with the strap muscle is also not clear. So I am summarizing the finding. Although venous phase was not available to us, but in this case we did all phases. So basically, this is a relatively ill-defined artery enhancing and lesion also in washout in the venous stage with fat plane, ill-defined fat plane with the strap muscles, and posteriorly the fat plane with the major vessels is not clear, and this lesion is causing mildly mass effect over the trachea, however no invasion is seen. So in view of large lesion heterogeneous enhancement, we get the possibility of thyroid carcinoma in this case. Moving to the next slide. So this is a image not from this, but taken just to show it how normally parathyroid adenoma looks like. Normally, the parathyroid adenoma is arterial enhancing and it is more enhancing as compared to the thyroid group. Basically, there are different pattern of enhancement. So typically, these adenoma are having smaller size, mostly more than less than 2 centimeter, approximately 1 to 2 centimeter, and enhancement is relatively homogeneous enhancement. Here in this case, we can see a lesion is quite large in the size, more than 2 centimeter in the size, and enhancement pattern is heterogeneous. In this case, and apart from that, fat plane is not as clear, and we can see the left lobe of thyroid lobe is showing a poor fat plane with the lesion. So I kept as a possibility of parathyroid carcinoma, which is arising most probably from the inferior gland.
Okay.
Are
Thank you,
we
ma'am.
moving?
Thank you. We went ahead with indirect laryngoscopy, which showed bilateral mobile vocal cord, and we also did a sorry. We also did a evaluation of the BMD, and it had osteoporotic T score of maximum minus 4.8 in the lower end of radius. With the diagnosis of a persistent primary hyperparathyroidism and with a high suspicion of parathyroid carcinoma, we went ahead with bilateral neck exploration and intraoperatively. One second. When we did a surgeon performed sonography, the lesion was localized near and infiltrating inferior pole of the left lobe of thyroid, and we did a left hemithyroidectomy with parathyroidectomy left inferior, and the on gross the tumor was weighing 29.8 gram and had a dimension of 6 into 4 into 3 centimeter. It was pale, white, and fleshy, and it was infiltrating the lower thyroid, uh, right thyroid lobe, inferior pole, and also the anterior muscles. And the rest of the parathyroid were seen, and it was clipped. In the post-operative period, intra parathyroid monitoring was also done, and it showed a more than 50% decline of PTH levels. And in the post-operative period, on the post-op day 2, patient had one episode of symptomatic and biochemical hypocalcemia, and which was managed with single IV bolus. Rest of the post-operative course was normal. She was started on oral calcium and vitamin D, active vitamin D supplement, and currently patient is on follow-up, and uh, uh, to to describe the histopathology, I would like to invite Dr. Sushila ma'am, Professor, Department of Pathology, for throwing some light on the pathology of the specimen.
Am I audible?
Yes, ma'am.
So we received a left hemithyroidectomy specimen. Please, next slide. This previous slide, previous gross specimen. So we received a left hemithyroidectomy specimen with left inferior parathyroid along with strap muscles. Combined weight of this was 26.6 gram, and on cut section, left inferior parathyroid showed well-defined solid nodules measuring 4 into 2 into 1.6 centimeter, and part of a thyroid measured 2 into 1 into 0.5 centimeter. Outer as well as the cut surface of thyroid was largely unremarkable. Next slide. And this is the HE section of frozen specimen, and the outer surface we can see is inked, which is black in color, and showed on one side, the upper one is the thyroid and the lower one is the tumor. And next slide. We can see the muscle which is encircled, black circles. So we can see the muscle is surrounded all around by the tumor. Next slide. And all these are frozen sections, and in the tumor we can see the tumor lobules. They are surrounded by broad bands. Next slide. So on frozen sections, because the tumor was touching the thyroid, so it is the distinction between the thyroid and the parathyroid tumor could not be made, and the tumor was infiltrating the muscle. So the diagnosis was deferred for histopathological and immunohistochemical examination. So now this is the H&E stain section of a definite sections of a H&E stain from the thyroid as well as the parathyroid. Here we can see the thyroid is absolutely normal on definitive section. This is a low power. Next slide. This is a H&E sections from the parathyroid. We can see the tumor is disposed in lobules and surrounded by thick, broad, fibrous band, which is extended, these bands are extension of the thyroid capsule. Next slide. And if you see the tumor proper, the tumor is showing monomorphous in histology. They have round nuclei, mildly pleomorphic, this cellular nuclear pleomorphism, and prominent nuclei, and pale amount of eosinophilic cytoplasm, and mitosis is rare. This is less than 3/10 high power field. Next slide. And on the outer surface toward the capsule, previous one please. So on the outer surface we can see there is a vessel which is surrounded by this capsule. So there is a vascular invasion. Next. And we can also see these encircled one, these are the nerve twigs. So these are the, and the surrounding this nerve twigs are the tumor. So there is a perineural invasion. Next slide. So this is a high power of another focus, the large nerve twig surrounded by these tumors, lobules. So this is a perineural invasion. Next. So now the question is whether this tumor is arising from the thyroid or parathyroid. So for this, the tumor origin, we applied immunohistochemistry, that is GATA3. GATA3 is important because it distinguishes between thyroid origin or a parathyroid origin. So GATA3 is positive in parathyroid and it is absent in thyroid. So here we can see the nuclear positivity in these lobules. So confirming it is arising from parathyroid. Next. Another two markers, thyroglobulin. Thyroglobulin is seen in thyroid parenchyma. So the lower one is thyroid. We can see here there is a brown positivity in the thyroid, while the upper one is a tumor which is negative. So further it is confirming that the tumor is not arising from thyroid. Next slide. Another third marker, immunohistochemical marker for thyroid is thyroid transcription factor, which is also positive in thyroid follicular epithelial cells, but not in parathyroid. Here we can see the right one is the thyroid, which is positive, and the left one, which is our tumor, that is parathyroid, it is negative. So it is further confirming that the tumor is of parathyroid origin and not from thyroid. Next slide. So the final diagnosis becomes parathyroid carcinoma. Next slide. So essential diagnostic criteria for parathyroid carcinoma according to WHO 2017 is that if any of these marker and any of these histological features are there, then we can label it as parathyroid carcinoma. So what are all those features? These are angio invasion or the vascular invasion. The second one is lymphatic invasion. Third one is perineural invasion, or a malignant invasion into the adjacent structures or organ, or the distant metastasis. Here in this case, we had not a single feature, but we have three features: angio invasion, perineural invasion, as well as the invasion into the surrounding strap muscle. So the diagnosis we have made is parathyroid carcinoma. Next slide. The another desirable or the diagnostic criteria according to WHO 2017 for parathyroid carcinomas are use of ancillary biomarkers. For example, in immunohistochemistry, we can also use Ki67, parafibromin, and galactin-3. And in mutational analysis, we can also go for germline and a somatic genotyping. Next slide. So the other features of parathyroid carcinoma, which are considered as worrisome features for pathologists, these are the triads of histological features. For example, one is coagulative necrosis and increased mitotic activity of more than 5 mitosis per 10 square millimeter and prominent macronucleoli. So if all of these features are present in pituitary adenoma, so this should be considered a worrisome feature for malignancy. Next. Other than this, what are the immunohistochemical features which can be suggestive of parathyroid carcinoma according to WHO 2017? These are loss of immunohistochemical expression of parafibromin, APC, E-cadherin, P27, BCL2, MDM2, and 5-hydroxymethyl cytosine, and positivity for PGP 9.5, galactin-3 entered, and overexpression of P53 or and Ki67 labeling index is more than 5%. But out of these all features, parafibromin loss of immunohistochemical expression is considered as the most reliable feature for diagnosis of parathyroid carcinoma. Next.
In the post, thank you, sir. Thank you, ma'am. Thank you so much. And in the post-operative period, patient is on regular follow-up and asymptomatic at present with a normal PTH and calcium level. Thank you so much.